Good afternoon and welcome to yet another live talk show here on NTV, where we will be discussing sexual reproductive health and rights. Some call it SRHR within the country. Now, this show will identify and address the key challenges and the obstacles along the investment chain, from mobilizing funds for young people's sexual and reproductive health and rights to budget priorities and the needs. But what are the sexual and reproductive health and rights? Well, there's information to safe experiences of sex. There's also family planning with options and choices, safe conception, maternal health care, and safe motherhood, cervical and breast cancer screening and treatment, the diagnosis, prevention, and treatment of sexually transmitted infections, HIV and AIDS prevention and treatment, post-abortion care, prevention and management of sexual violence against men and boys, as well as women and girls, including harmful cultural practices such as female genital mutilation and post-rape care. Now, this is not the first conversation we have had in this particular bit of things. We had one where we took a look at the budget, its funding, and how there were possible solutions that could be brought about. But today, we'll also be having another conversation. I am Rita Kanya, and I will be your moderator. And now we have a group of panelists who are joining us this afternoon. Just next to me is Dr. Hizam Ramadan, who is a researcher of the World Bank, but a specialist today when we're taking a look at public health within the country. Welcome to NTV, Doctor.
Thank you.
And next to him is Akelo Caroline, who is a member of the Uganda Women Cancer Association and also a survivor of breast cancer. Welcome, Caroline.
Thank you.
We're also joined by Margaret Happy, who's a policy and budget analyst consultant, and she's joining us via Zoom this afternoon. And as we get into this conversation, we'll start with, you have seen the statistics, we have heard of a number of statistics, Doctor, but from your end of things, what is it really like on the ground at this point in time when it comes to SHR service access?
Thank you. The situation on the ground in terms of access to SRHR services is definitely challenging, just like in other situations in the country. Access to healthcare services remain low, especially when you look at the rural communities, given the fact that we have fewer doctors in the rural areas, yet the biggest part of the population is in the rural areas. And the concentration of health workers mainly in Kampala, Uganda, around urban areas. And that means that even access to SRH services is constrained in terms of availability of services itself, in terms of geographical access, the distances people have to travel to access those services, but also on the nature of services being provided, to the extent whether they are friendly to the users is also another issue. You have social issues surrounding SRH services, and then you have economic issues, financial issues in terms of affordability of those services. So those are some of the issues that normally rotate around access to and utilization of our SRH services in Uganda.
And would you say in one way or another policy could be something that could change that?
Policy is one thing. Putting policies in place is one thing. The policy practice could actually be a very different thing. If the practice is poor, if the resources are insufficient, even with the right policy in place, you still have to get those challenges. It boils down to issues of management of the healthcare delivery system. Because in some districts, you find services are good by nature of governance and management. In some other districts where management is different or may be poor, access is a limitation. So there is always that controversy between policy and practice, which hampers outcomes of the policy intents.
So who do we start to point the finger to when it comes to practice?
Practice. Who manages the practice or policy implementation? Policy implementation is at the point of action where services are supposed to be delivered. But who monitors the policy implementers comes from the top. So linking the two, we may not point at a particular entity in terms of policy outcomes, but it is a combination of the two entities. The policy makers, the policy implementers and policy implementers are looking at the actual individuals who are on the ground, the frontline workers. If you do not provide the frontline workers with sufficient resources, even when the policy provisions are very good, they will get constrained. Look at the human resources for health in terms of numbers. I don't think there are any facilities up country which can indicate that they have filled all positions required to deliver a comprehensive or minimum package of healthcare services. When you look at the resources themselves, they keep dwindling. We don't have an increasing budget allocation for healthcare, and that impacts on the kind of service. But remember, the population is growing day in, day out. The service needs are increasing. The disease burden is also increasing, but it does not speak to the resources that are allocated for healthcare. It does not speak to the number of healthcare workers, but also the skills and competences of healthcare workers. So there is a disconnect among those different elements. And the resultant effect is poor or limited access to quality SRH services in the country.
Okay, well, when we just bring in Caroline into the conversation, when you talk about the quality, Caroline, you're a survivor of breast cancer.
Yes.
When did you discover that you had breast cancer?
It was in 2018, around the month of July.
How old were you then?
I was 32 years old.
Okay. Now, just wrapping your head around what had been told to you and moving forward, you're a part of the Uganda Cancer group. How is that, the Uganda Women Cancer Association? How did that change for you a number of things in your life?
The association is a very good thing because from the day I was given my results that confirmed I had breast cancer, there was the director of the association came and talked to me because she's a breast cancer survivor herself, to encourage me, to let me know that it doesn't mean that it's the end. Yeah, because what I have realized, most people think that having cancer means death. So the association has really been a great support.
Okay. Well, what you mentioned is the association is more of a private group of people coming out to help and meet that need doctor. And when you highlight the fact that there's a disconnect, and of course a number of people in the country are always asking the government to step in everywhere, but then they also say we as individuals can do something. Where should the private citizens come in and say, you know what, we can take this burden on, we can help in ensuring that the SRHR services are accessed by each and every person in the community?
You know, healthcare is a function of the individual. Before even the private sector comes in, there must be enough sensitization of the individuals to appreciate on the way they perceive their own lives. Then they can be supported along that cause. Now, with weak health promotion services, or health education services, definitely they impact on individual awareness about their health. Even when the private sector comes in, when the individuals are not aware about how they should take care of their own health, however much you put policies into place, it will not change their lives. So I think private sector comes in to help the government, especially in creating awareness, in advocacy, but also in service delivery for those who can afford to pay. It comes in to bridge the gap in service delivery. And in my opinion, both the private sector, the individual and government must be seen to be working together to be able to address the needs, the various needs of society, because the society we live in is multi-layered and our needs are equally multi-layered. They may not be sufficiently addressed by government itself, nor the private sector or other sectors. So depending on my need, I will know where to go. But I must first of all know where and when to go.
Okay. Yeah. Well, let's bring in Margaret Happy, who is a policy and budget analysis psychoanalysis consultant here in the country, and she's joining us via Zoom. Now, Happy, you have been a part of our conversation, the first conversation, now the second one, and Dr. Hizamu has mentioned something, which is people need to, first of all, know about these services. From the research that you have carried out, what do people know about these services?
Hello. Yes, my name is Margaret Happy, and thank you so much for connecting me to this very important subject. I carried out an analysis of the budget. I did a budget trends analysis on sexual and reproductive health and health financing for the 3 financial years of my country. That's 2018, 2019, 2020, and 2020, 2021. And when I did this budget analysis, I also looked at the government's commitment, issues to do with the sexual and reproductive health and rights, and with a particular interest among the young people, is also aligned with what the government has planned to do. I just want to make reference to the recent commitments that my country made through the Nairobi Summit on ICPD 2025. My president, in my presence, actually recommitted to the Family Planning 2020 pledge to continue promoting universal access to all methods of family planning and to reduce the unmet need for family planning from 28% to 10% by 2020. And when I talk about 28%, that is for the general population. But considering the age group, the young people we are looking at who are 15 years to 19 years, their family planning unmet need stands actually at 30.4. So 2020 is not far from now, that by that time, collectively a lot would have been made for us to be able to achieve the commitment that we made to FP 2020. But at the same time, my government, through His Excellency, the President of this country, committed to stand firm to eliminate obstacles that stand in the way of girls' empowerment, such as teenage pregnancy, child marriage, as well as all forms of gender-based violence. But we know that amidst all that, we still have 1 in every 4 girls aged 15 to 19 who are already mothers in this country. That's according to our UDHSS. And we also know that around 17.6% of pregnancy-related deaths are actually from the adolescents aged 15 to 19. So without taking a lot of time focusing on the progress that we have made towards achieving the targets under sexual and reproductive health, I also want to look at our commitments in terms of resources, because I've heard from my colleague who is on the panel that, it's one thing to have the policies in place, but when it comes to the actual implementation, it's a different thing. Let me quote the Abuja Declaration. My government committed to commit 15% of our national budget to health sector. But whether we have realized that or not, I'm just giving you this information. And I actually know that our health sector is very critical in producing a healthy and productive population that is supposed to contribute to the achievement of Uganda Vision 2040. I also understand that all these financial years that I have the budgets for these financial years that I have analyzed, the health sector priority actions, resource allocation, are in line with our National Development Plan 2, and now 3, which is still a draft but yet to be approved. So in terms of when you compare the nominal sectoral allocation, because we are talking about commitments, to sexual and reproductive health, but commitment comes along with money. That's why I like speaking about money. It's one thing for us to have these policies. It's one thing for us to have the budget, to have the legal framework, but it is another thing to actually ensure that the adolescents and young people have full information on sexual and reproductive health and rights, and their needs in terms of access to contraceptives, options are, are addressed, and also access to, to services that facilitate safe delivery is met, and all that is reflected in the monies. And we know that our national budget is also one of our key policies. And I'm just going to focus on our national budget, because the national budget will clearly show whether the people have access to the services, or whether it's more of rhetoric than the actual commitment we are talking about. So in the financial year 2018-2019, we have approximately 29 trillion Ugandan shillings, but the share for the health sector was around 2.42 trillion, which was around 11%. Okay, we were moving towards achieving the 15% of the Abuja Declaration. But what happened the following financial year? In the financial year 2019-2020, instead of increasing to maybe 14 or 13, we actually reduced in our allocation to the health sector, which was reduced. Okay, it was increased to 2.5, but in the current financial year, it reduced to 1.5 trillion, which is around 5.1%. And to me, that is not a good signal when it comes to fulfilling our commitment towards Abuja Declaration. And so I went further to analyze the budget and allocation to do the interest health allocation, and I realized that under the recurrent expenditures, specifically wage allocation, when you compare the trend.
Before we analyze that bit, just to bring in Dr. on this particular bit, Dr. Ramadhan, when we notice that we're taking one step forward, then we go backwards, yes? In terms of the budget, we say, yes, now as a country, we shall give more here. Then the next thing we see is that there's a drop. Are we seeing that perhaps maybe there's progress made and maybe there's now a lag? What happens in such situations? Because, I mean, we can't continue to recommit to particular international agreements, but when it comes down to what we're seeing, it's totally different.
You have to appreciate our annual budgets. They change, they are dynamic, depending on the government priorities as at that time. The priorities last year cannot be the same priorities as this year. And the expenditure lines that government may want to take in the previous year may not necessarily be extrapolated into the current year because of the changes in government priorities. You also have to consider that the coronavirus, the pandemic, has had a toll on government economy, but also in the general global economy. So for that matter, you wouldn't expect government's budget to increase within constrained income, national income, because it has affected every sector of the economy. So you are likely to have lower budget performance and therefore lower allocations, the different sector of government. While I wouldn't have loved to see a reduction in the budget allocation from 11% to about 5% she's talking about, okay? Because that's going to be reflected in the kind of service delivery. We are likely to have a very bad situation in terms of healthcare service delivery. So the ups and downs are definitely not good for the final service user, because at least we had averaged at around 8% over the last 8 or so years. It's, I think, in this unfortunate event that has actually gone down to below 5% of the national budget. So it's not a good thing, definitely, but sometimes it's inevitable.
Okay, when we bring in, still talking about those ups and downs, Caroline, you have, I don't know if you have experienced the ups and downs in terms of engaging with the young people when we see such a drop in maybe just how much money is allocated and how it eventually affects the services they receive. What is your experience with this?
For me, I think it's a good thing for the government to give priority whatever it looks at as a priority. But when it comes to health, most especially to young people, it's a very important thing. And it's it's really going to affect the young people, because I believe the young people need information, most especially when it comes to issues to do with cancer, breast cancer, cervical cancer. They need information, and to give that information to them, of course, usually it comes from money. So if money is being reduced in the health sector, it's the end user who is going to suffer. And if they don't have this information, they might fall victims to cancer themselves.
Okay, and what about the association? What strain does it put for the association?
For the association, what I can say is we've always had donations, most especially from other countries, let's say from the US and other donors who want to support cancer.
Okay.
Yes.
Well, doctor, you mentioned something earlier about if an individual is informed, if the health worker, one, is catered to properly in terms of their payments, they are able to actually deliver these services in the best way they can, one of those ways. And Happy, earlier you were mentioning something, if we could just get Happy, who's on Zoom with us, to tell us about how the relationship between the wage that the ministry continued to maintain and also how it lacked in terms of the fact that, yes, you're paying for the health, you're paying the health worker's wage, but what about the resources that are being given to the community? So over to you, Happy, on that budget analysis there.
Thank you so much, Rita. When I did intra-health sector budget allocation, I realized that the allocation for the recurrent budget, but specifically looking at the wage, in the financial year 2018, from financial year 2018-2019 to 2019-2020, there was an increase, which was a little good sign. But comparing the previous financial year with the current financial year, there was a stagnation. And yet, this happens at a time when we have increased in the number of our health center tools from 1,693 in financial year 2019-2020 to 1,818 financial year 2020. We have projected that. And also health center 3 increased from 1,094 in financial year 2019-2020 to 1,818 in 2020-2021 projection. And we have around, we have elevation of around 10 health centers to health center 4. So this amount that has been stagnating for the last these two financial years will hardly match the increasing staffing levels to serve the planned upgrading of the facilities and the growing population. We know that our population is not stagnant, but when it comes to the budget allocation for the wages, it is stagnating. And to me, that creates a very huge question in terms of human resources for health at all levels. Are we going to have enough providers who will be able to serve the growing facilities? Are we going to have enough providers in all these facilities that have increased, yet when it comes to the wages, it has stagnated? Are we going to be able to provide the quality of the services that we are talking about? Universal health coverage. Universal health coverage does not only come with the structures. It is one thing to put up the structures, but it is another thing to ensure that those structures which are put in place are functional, they are operational. So yeah, so that creates a huge concern. And for the young people, adolescents and young people, if they are to access these services, they need to find the providers there. But how are we going to sustain the providers when the wage, if the wage is still stagnant? Over to you, Rita.
Thank you so much, Happy. Now, with that wage in mind, it brings in the public. One, on the front that maybe the next health worker, who could be the next health worker, may not go into that particular line of profession because of the trends that they see in terms of money, how much they can earn. But also, secondly, the motivation of the health workers, doctor. Yes, the relationship there.
A relationship between money, the wage, and the motivation. Money or the salary is necessary, but not sufficient to motivate somebody to work. For somebody to be motivated beyond the money that one receives, you also look at the work environment. How facilitating is it for somebody to be able to exercise and practice his skills and competencies? So you're going to find that even with the health facility there, that's the infrastructure, with a salary available, even if you increase it, but if somebody has no tools to be able to deliver a service, the motivation will not be there. So there must be a correspondence between the money that one receives and the ability for somebody to do his or her work. So the healthcare workers need to be motivated also in terms of being equipped or tooled to be able to respond to the needs of the service users.
And where would we bring in the trust of the public? And perhaps we'll start with Caroline there, because the trust, even if we have motivated them, but what we know as of now, you know, if you go to a public health center, or even if it's a hospital, there's this mentality that many have that you have to give something just a little bit more, or there may not be any medication there, or you're going to have to go and wait for long hours, you know, to access things such as just cervical and breast cancer treatment. I don't know how your treatment was like, Caroline, and maybe you can take us through the treatment there.
Okay, for treatment, yes. Let's say from the onset of starting to do the tests, then you have to take a biopsy, and there are other tests that you need to know your heart is functioning well, so you can take the treatment. So it usually takes time. It takes some time, because I remember taking about 2 weeks to get my results.
Which particular hospital were you using?
At Uganda Cancer Institute.
Okay.
Yeah.
So 2 weeks to get your results.
Yes.
And then how was the treatment like?
Yeah, there is waiting. It really takes patience. But I also don't blame the hospital, because when you look at the numbers of the patients compared to the number of the health workers, it's really overwhelming. The nurses have become my friends, and I really appreciate the work they do, because sometimes these nurses come in the morning and up to around 5 o'clock, they have not even taken a cup of tea, because the patients are too many and all these people are looking for help. They really need the help. So there is also a gap when it comes to the number of the health care workers and the number of patients. So that is where the challenge is. And because of that, many people have found it hard to go to the main hospitals, because they don't want to wait. But the problem may not only fall on the health workers themselves, it also falls on the fact that the number of patients is really, really high.
Okay, and where does it, what situation and what state of mind does it leave a patient who is just simply trying to get treatment for you?
Sometimes it's frustrating.
Okay. Now, Doctor, when you hear the frustration, there must be an issue with the public's trust. And even if we say the policies are right, the budget, the money allocated, the health workers, bring in the mentality that the public has when it comes to just treatment, or even going to check testing for whether it's HIV and AIDS, or even just cancer.
You know, it is not correct to say health workers do not present themselves well as a blanket statement. I know of health facilities where you go and the reception is very good. So sometimes we are dealing with individual characteristics, but they all boil down on the leadership and the management of a particular health facility, or leadership and management of the entire healthcare delivery system. Because in healthcare we have the supply and demand side. The supply side is the service providers. The demand side is the service users. The question is, have we tried to harmonize between the expectations of the service users to those of the service providers? The disconnect between the expectations of the two entities leads to what you're talking about. That
Misconception.
Yeah, and there is that stereotype that Uganda's healthcare system, public health system, is bad.
Yes.
On the contrary, you need to interface with the system to appreciate the little they are able to do, or the much they are able to do with the little resources available. So because of that and the limited awareness of communities, of the public, about the nature of services they should get at a particular level of health facility, could also bring a problem. You have a certain disease that do not warrant you to go to a health center for. You go past health center 2, past health center 3, simply because for you, I think you don't want to interface with a lower level health facility, and you only have malaria. And you want your malaria to be treated in a district general hospital. Okay, then when you get there, you are told to line up with so many other malaria cases. Then you begin complaining of waiting time. But waiting time, from what angle? Have you come to the right health facility level, depending on the nature of the condition, or you are referred from health center to, for you want to go to Mulago, simply because you are a certain somebody in society, okay? So those misconceptions about the kind of services supposed to be delivered at the levels of health facilities could actually be one of the drivers to the misconception about the nature of services delivered.
When you mention misconceptions, and when we bring it back to SRHR, misconceptions that a 13-year-old cannot come to a health facility trying to get access to these particular services. Yes? Let's bring back the conversation to misconception in that particular area, because if health workers are not aware that a 13-year-old can actually walk in, because when you see such statistics of adolescents between 15 to 19 contribute about 17.6% of pregnancy-related deaths. Over 44% of 7,200 annual maternal deaths among females between 15 to 24. Are we burying our heads under the sand and not realizing that actually children, yes, we can call them children, adolescents, are engaging in these activities, and we now need to welcome them into these conversations about what they should do right and what they should do that is not right?
There are a lot of controversies about that age subcategory. Because when you look at the National Comprehensive Sexuality Framework, which is supposed to target such a kind of age groups, it has been met with a lot of resistance, especially from the religious leaders. Okay? And that it amounts to burying our head in the sand or hiding behind a finger. Okay? Because things are happening in that age subcategory. But then the law tends to constrain on the way we approach them. Okay, they are getting abortions, unsafe abortions, and they are not getting contraceptives because the health workers are working within policy guidelines. But we also know that this age subcategory is very sexually active. So that controversy between the policy and then the practice or what is actually happening on the ground brings a lot of issues in terms of addressing maternal death. So it's a policy issue, but it requires also a lot of political will to be able to, and social will, to be able to overcome such a kind of barriers. The religious leaders are preaching against some aspects of family planning, modern contraception. Some religious sects preach against it. But the fact is, part of their congregation is busy in that act, and they are likely to die. So I wonder whether what they speak in public is what they also speak in private. That's another matter.
Yes, and that matter in particular is only being brought to the top during this COVID-19 pandemic, with all the reports that have come in from different parts of the country, the increasing teenage pregnancies, and just wondering what is going to happen next for these adolescents, even just children, because I mean they have a life ahead of them. A life that perhaps conversations that could even be had in the community, because you say that yes, the congregation sometimes knows these things. You know of something that's going on, but it's wrong, and still that brings in the public. Can a mother just simply walk into a particular health facility with her child and say, yes, my child might be this age, but I want this conversation to start, this access to happen?
That's a social issue. Parenting is a complex social issue. And a mother that would walk in with a daughter of 12 years asking for contraception, that would be a very courageous mother, okay? But on the other hand, what does society talk or say about such a kind of children going for services? Does the healthcare delivery system in Uganda take into account such a kind of concerns? If you go to a health center 3 or health center 2, any lower level health facility, Are there facilities that enable the young access the services without necessarily interfacing with the adults? If a child wants service, SRH services, in the same facility that the mother gets the services, is there any provision? Definitely most health facilities don't have those kind of provisions, both the physical infrastructure provisions, but as well as the service, the skills and the capacity of healthcare workers to be able to address those segments of needs by the different levels of service users.
Wouldn't you think there is a need for a change in policy because the times are changing? Would you say our policies are up to date with what's going on within our country, the practices? Because you mentioned the policy framework that some of the health workers are working with, but say it is not right for you, besides social, but the policy is saying, no, this child shouldn't have access to things like this. So a change in policy, is that needed?
But Rita, you know, Uganda's policy making processes, even when a policy might be going to give us good results, the social cultural aspects come in and they are played within the political dynamics. Okay? Who doesn't know that children 10, 12 years are getting pregnant in Uganda, including those who are preaching against? Who doesn't know?
They all know.
Including their daughters. They know it. But then there is that religious line you have to toe. You toe a particular religious line even when you know that the practice is different. So even passing a mere policy, making that policy go through the due processes will actually be met with a lot of resistance. Okay? So sometimes it required very tough political will and decisions, okay, to make a particular decision and say this one must go through and then empower people down there to implement the practice. Okay? So those are policy dynamics. Okay? The comprehensive sexuality education framework is available. But what is the practice? You cannot go out right there and begin implementing it. Remember, some of these schools are owned by religious bodies. You can't step your foot there. But these are the same children coming from our society into those schools. So while some aspects of society is getting information about this, the young children miss out that opportunity of getting information. So they end up getting such information from their peers. And what kind of information do they get? Unfiltered, unscientific information, and that gets them into the practice. So at the end of the day, you are seeing those cases of teenage pregnancy, especially in the COVID era when most children are in their home. And that goes back to parenting. How much are the parents empowered to empower their children in light of the social cultural constructs that guide most of our homes in the way they operate and the way children interface with their parents? So parenting becomes an issue. That one goes even beyond the healthcare delivery system and delves into the social sector in terms of psychosocial support to children, in terms of counseling and the issues of the sort. Yeah.
Well, Caroline, you have received, I believe, psychosocial counseling and support from the association. And does that go further into the young adolescents at this point in time when it comes to breast cancer and cervical cancer awareness?
When it comes to cervical and breast cancer awareness, I really feel there is a great need for it to be localized. It would be a good thing for it to be included in the schools as part of the reproductive health education for the young people, because they really need this information. Let's take a look at cervical cancer in particular. Cervical cancer is something that is caused by a virus called the human papilloma virus, and this virus is sexually transmitted. So meaning if a young person starts having sex at an early age, they have a high risk of acquiring this virus, meaning they also have a high risk of acquiring cervical cancer. And cervical cancer is like the highest killer in women in Uganda. And yet when you look at this, it takes 10 to 20 years for the virus to grow and become cancerous. Meaning for a person to really have let's say cervical cancer, and in their late 20s or early 20s, it means they really started having sex at a very early age. So it's very important for young people to be educated about this. And this is information that they do not have.
And I think, back to you, doctor, taking a look at cervical cancer, breast cancer, as one of the things within the sexual and reproductive health and rights that has not been brought to the forefront, not seldom talked about for young children and adolescents. Do you agree, or do you, in one way or another, say no, this conversation has been had?
Subjectively, I agree. Objectively, I don't have evidence.
Okay.
But it is definitely an issue. It also goes with our healthcare seeking behavior in rural areas, especially even among the young children. We only take these children to hospital when they show signs of sickness. It is very uncommon to take children to hospital for general medical checkup, including cancer screening. Okay? It's not a common practice. So by the time such a kind of disease surfaces, sometimes it is too late. If a child starts engaging in sexual activities at the age of 11, 12, okay, it is normally hidden. It's not overt. They hide there. By the time you recognize what is happening, sometimes the child has been in practice for the last 10 years, and by the time the child is 20 years, you are not aware. And sometimes during that process, the virus is already there. The child goes to get married, goes and gets married, and in the process of reproduction, you begin seeing those issues coming up. For you to make a retrospective analysis to see could this child have gotten the disease, it is very difficult. Perhaps if that kind of screening had been done at that early stage, it would have helped to identify such cases. Now, unless you have policies that make it compulsory to do screening for such a kind of diseases on an annual basis, like before we take our children every time before they go to start it, they are screened for pregnancy and some other STIs. It is a routine. Supposing they make it a policy issue and also do cancer screening at that level, perhaps it would help to unearth some of these conditions, and they are able to be managed early enough.
Okay. Well, that's a recommendation that you make, also one that Caroline has made. Happy, what recommendations did you make with this report after your findings?
Thank you so much, Rita. I've just heard Dr. made a very beautiful recommendation of routine screening. But because I'm interested also in looking at the budget, interested in looking at the money, because political will and commitment are reflected from the resources. So when I did the budget trends analysis, I realized that we are having a huge concern with funding gap for non-credit line commodities. And among these, with the reproductive health, for the financial year 2019-2020, we had a funding gap of 57, specifically for reproductive health commodities. And in the financial year 2020-2021, it's actually at 62%. And that is caused by stagnating funding to our national medical stores, which is even actually going to worsen the stockouts of essential commodities, which includes reproductive health commodities like mama kit. NMS in the financial year, for instance, 2019-2020, was given approximately 396 billion Ugandan shillings. And now in the current financial year, the projection is the same, 396 billion. And we are saying that we are having serving a growing population. We have we have planned to serve the planned upgrading facilities, which requires a lot of resources. And so if the young people go to the facilities, the nearby facilities, health center tools, even at VHT's level, and they cannot find contraceptives, what do you expect? I had doctor also say that, we need to have this routine screening, but we still have a funding gap, even for our laboratories. Among the key things I'm talking about here, HIV test kits, cervical cancer screening, hepatitis B screening, all these and others, all these fall under the category of reproductive health. But the funding gap for the financial year 2019-2020 is 46%. And then for the financial year 2020-2021, it's around 17%, which is huge. And when I looked at the different health facilities, the unfunded gap for the commodities, for instance, for Kawempe here, which is known as a women's facility, Kawempe National Referral Hospital has a funding gap of 69 in this current financial year. And we are also having a huge funding gap for commodities at Health Center 2s, 62%, Health Center 3s, 34%, Health Center 4s, 49%. I mean, this is very, very huge. So AMED is having the funding gaps for the key commodities, and specifically I'm now looking at reproductive health. We also reduced in our budget allocation for primary health care, and it is primary health care which is supposed to help us pass on information for prevention, for management of different health conditions, including health conditions that fall under reproductive health, and controlling them. And so if we are still having a reduction in allocation for the primary health care to local governments, then that is creating a huge concern to all of us. And we know that it is under primary health care where we are addressing concerns around maternal, child care, including family health, family planning. We are supposed to be having a lot of education on the prevailing health problems, you know. So commitment comes with money. It is the money that we are lacking.
Thank you so much, Happy. She has made the recommendations, but what is lacking is the money. I don't know if you both agree as we wrap it up, what else is lacking and what solution would you give to the government when it comes to access to SRHR services?
I wouldn't say that the quality of health service is a function of amount of money received. Money is a facilitator. There is an element of management and leadership. What results do we have to show for the little money that comes in is an issue of leadership and management at the health facility level in terms of service delivery. So we also need to look at how effective is the leadership and management function at the health facility in light of service delivery. And two is there is a tendency of overdependence of on government funding for our health care. So the question is, while government is looking for money to give us good health, what is our role in terms of also contributing that service? And the concept of health insurance comes in. You know, always free things are always problematic. Yes. And when you don't contribute that free thing, when you don't contribute towards the service, even accountability becomes an issue. We cannot hold health care managers in terms of accountability on resources that we do not directly contribute to because we don't feel it. This money comes through the taxes that we pay and finally goes to the health facilities. In the past, we used to pay graduated tax and then would hold the service providers accountable for our money. Okay? So bringing in the concept of health insurance would actually work.
But that has been a very contentious issue
of
when it comes to health insurance. Yes, within the country.
It is contentious because it has a lot of political connotations. The bulk of the communities that should contribute that money are within the informal sector workers. And they're actually the heavy users of these services, especially rural health care services. And they do not contribute co-financing for those services. So it is, unless government comes in with a very strong point of view and standpoint of view to enact the current bill, National Health Insurance Scheme bill, that has been pending for over 10 years, okay? And the constraining factor is the community health insurance scheme perspective. That is bringing a lot of problems in terms of its implementation. I did my research in that area, and that will be another story another time.
Definitely. Now, Caroline, as we wrap up, any solutions that you would want to pass on, any recommendations to the government when it comes to access to SRHR services in the country?
For me, what I think can help is for these services to be moved closer to the communities. most especially when it comes to cancer, because when I look at it, people have to come to Kampala to do most of these tests and all that and get this treatment. But if these services are moved closer to the communities, it would make it easier to access. But also on the other hand, it goes back to individuals, it goes back to the families and all that, because cancer is more of a lifestyle disease than anything. So how do we feed, how do we live our lives? Yeah.
Okay. Well, thank you so much for joining us today on NTV. The conversation was how identifying, addressing the key challenges and obstacles along the investment chain for mobilizing funds for young people's sexual and reproductive health and rights, budget priorities and needs. Thank you so much for joining us on this conversation. I was joined by Margaret Happy, a policy and budget analysis consultant. She was joined us via Zoom. Dr. Hizamu Ramadan, who is a researcher at World Bank and also a public health specialist within the country, and Akelo Caroline, who is a member of the Uganda Women Cancer Association. Thank you so much for joining us today afternoon.
Thank you, Rita.
I am Rita Kanya and I was your moderator. Coming up is NTV at 1 with Andrew Chamagero. Have a good afternoon.